טוב לכולם. שוב ברוכים הבאים ותודה שבאתם. אני בטוח שהיום יהיה מאוד מעניין, מכיוון שאנחנו נעסוק בטכניקות גם של השתלות, גם אוגמנטציות. נדגים גם את הטכניקה של שימוש בבון רינג, שזו טכניקה של אוגמנטציה, יחד עם השתלות דנטליות בו זמנית. ואני בטוח שזה יום מענה ופורה לכולנו. I would like to welcome Professor Smith. He's been here for the second time, but I heard that this is not his first visit in Israel and not the second. So we welcome you. Please, בבקשה.
Thank you very much. Dear ladies and gentlemen, good morning everybody. Thank you very much for the invitation. Thank you to Professor Rachmil and all the best for him. I think this is the important thing in life. All the best way for him. And thank you Dr. Neu, Dr. Blank. I should give you some lectures this day. Sorry for talking about this, but it's only 4 times half an hour to talk all about these things. It will be very funny. Sorry, I will explain first of all. It will be short. It will be a little bit quick. Sorry for this, but I have only 30 minutes for the aesthetic zone. And I think you all know this even before, yeah? I'm Dutch, I'm not German, I'm Dutch, I'm working in Germany. And I was educated in England and America, and you will see after 10 minutes, nobody liked me in this room. Because, in my opinion, we haven't to talk about the products. The biomaterials are working. The implants are working. You did a great job in Israel, MIS and all the companies. I'm totally impressed. You have so many active guys here. The problem, in my opinion, is always our right hand. The soft tissue technique, yeah, the prosthetic things, the top-down planning. I'm oral maxillofacial surgeon, but we are one team. The periodontal guys, the prosthetics guys, the position of the implant, the top-down planning, the backward planning, we will see later. Only the 30 minutes, but talk about implantology. In my opinion, implantology is not so difficult in the molar region. The typical point is aplasia of the lateral incisor, yeah? The aesthetic zone between the canines. We have a lot of strategies of all the companies what we can do. I know around about 190 bone substitute materials at the moment in the market. It's amazing, yeah? Nobody knows this all, yeah? We know a lot about bone chips, bone spreading, distraction. It's coming more and more back to the roots. Yeah, we know the bone blocks are working. I'm a big fan of the blocks, but we will see later. Yeah, and at the end of the day, we are talking more and more about shield technique. You know, Curie, all these techniques. We know that a cortical plate, like the plate from Botis, like autogenous plates, what you prefer, they are working much better if you have a plate with a particle bone substitute material behind. It's working better than a bone block. You will see later in histology. I'm a big, big fan. You are all experts. You don't need Mr. Smeets. We can be honest to each other. The problem is we haven't the big literature. We haven't the data. That is the problem in implantology. Everybody's talking about implantology. We have round about 2,700, 2,700 implant systems worldwide, but we have less data. 483 companies, yeah, produce. From these 483 companies in a big paper, only 6 companies produce 83% of all literature, of all papers. Do you know what I mean? A lot of companies produce products, sell them, and they have never did any data, any valid data, any studies. Will you buy a Porsche? Will you buy a BMW when it never be tested? But you insert implants which have no data, no clinical, no animal studies, nothing. You know what I mean? MIS did a great job. Other companies did a great job. Straumann, Dentsply, all of them. But only 6 companies have literature. Sorry for saying this. In 8 minutes, nobody liked me. But we have to be honest. We couldn't about things. We couldn't talk about rumors and miracles, you know? I'm a big fan. I'm Dutch, and I like to be honest. We are colleagues. We are in one boat. Yeah, we have to be honest to each other. A case report, this is not research. A study with 20 implants is not research. You know what I mean? We have to need to get better studies. Sorry for saying this. And at the end of the day, to solve these problems, we have only 6 millimeters there, maybe. It's coming more and more the study of the second literature. of the second lecture that we use short implants or small diameter implants. We talk in Europe at the moment, all congresses, it's the same topic. Talk about zirconia versus titanium, talk about individual abutments, I'm a big fan of this, and the third big story at the moment is small or short diameter implants versus bone augmentation. But we'll see in the second lecture. Now we talk about the aesthetic zone. We know all these problems. Like Randall Sofer told us and the other guys, that's a typical problem in the aesthetic zone. Yeah? We know the thickness of the buccal wall. We know we have the problems. When you prepare a flap there, yeah, a flap elevation, you have resorption of the bone. 90% of the nutrition of the bone is by the periost. When you make a mucoperiost flap, you have less nutrition. You lose bone, and then you lose the buccal wall. Please keep in mind. We know the old story. These are old pictures. The fate of the buccal wall from Nevins, we know these pictures. Can you explain me where's the buccal wall? We have to protect the buccal wall, yeah? We're always talking about bone augmentation, about implantology. Once again, I'm surgeon, but the surgeon is not important, guy, yeah? Important is protect the bone, yeah? Protect the bone. Not only augmentation, not only implantation. Sorry for Botis, sorry for all the companies. But why you don't protect the bone, this is the important thing. But never forget, one of the biggest rumors in dental implantology, it's a big, big lie, you never have a higher bone potential. The socket preservation is only a pure protection against resorption. You have a less resorption. You never have more bone, yeah? Please, keep in mind. It's a famous paper, but the companies don't like it. You know the problem? Autogenous bone have no sponsor. You know what I mean? Very important, I learned from the American guys, is not the implantology. The soft tissue management, the peri-implant soft tissue management, and the extraction. The guy in Los Angeles I learned from, he takes more time to put a teeth out than to insert the implant. In the aesthetic zone between the canines is very important. When you move the buccal wall, you get microfractures, you get resorptions. Look at Berglund, look at Linde, the studies of Canullo, Caneva. They shows it clearly, resorption from 1.6 millimeters in the first 6 weeks. Even in the aesthetic zone, to achieve good results, yeah, keep in mind atraumatic extraction. Use periotomas, use piezo surgery, use maybe X-tool or Bannex system, vertical extraction. These are strategies. You see at the moment, dental implantology is getting more and more digital. And the second new way is getting more and more biological. Fibrin membranes, plated rich fibrin, looking more and more on the biology. Keep it atraumatically. You are all experts. I am only 10 years working. You have more experience, but everybody knows this. Dentistry is going more and more back to the roots, back to biology. Yeah? Keep in mind, yeah? We know this from Klein, always do it transalveolar. Avoid flap preparation. You have resorption 0.7 millimeters. Use periotomas and separation of the roots. Sorry for this. This is boring. Come on, guys. Yeah? We don't do a heart transplantation. Yeah? We don't do cancer surgery. This is only a screw in the bone. But we have some rules for this. Yeah? Please. No therapy, I think you will say this is bullshit. Yeah? Socket preservation, everybody's saying yes. But why don't you do this? Yeah? Immediate implantation, yes or no, we will see later in the fourth lecture about the concepts. Now I have only 30 minutes. What should we put in? Should we use some Cerabone? Should we use synthetic thing, the max result, the max rev? What should you use? Autogenous bone, a collar coin, what you like? Yeah, we can talk about. With or without a membrane. It takes a whole weekend to talk about all these things. You will see in the next lectures, which is my strategy. At the end of the day, you can laugh about me. When you leave the room, Boston Consulting and all the companies, we are trained in Germany, they are teaching us. I have to learn a lot in my life. I'm only 10 years working, but I learned one thing. A good lecturer, in 1 year, you must know 8 sentences of my lecture. Even I'm a bad lecturer, you know. When you leave the room, in 1 year, you must remember 8 things of my lecture, or I'm a bad lecturer. Keep in mind, I use the collar coin. You can use what you like, take what you like, but this is my strategy. Yeah, it's with porcine collagen and max resorb granules to avoid preparation and the resorption. The flap design we will talk later in the lectures and you will see. But I like to show you something new things. New, maybe is it really new? Look on Kakashi. I love this technique. Sorry for the companies. Maybe we don't use any bone substitute material. I take a crystal disc of the root and then you can avoid the resorption. It's like a crystal disc of the tooth. You put out the teeth, you clean it, then I take a crystal part like a disc and put it there to manage my alveolar. Look on Kakashi, look on these guys, it's working. I love it, you know. It costs you no money, zero, and it's working. Sorry for the company, but this is modern implantology, back to the roots, and it's working, believe me. Yeah. But before we start, very important, keep in mind, I love these easy slides, I love these easy samples. The selection of the patient, the defect morphology is important. Do we have a bisphosphonate patient, irradiated patient, a smoker, all these things? The surgical technique, my right hand is important. The soft tissue management is the goal to success. Tangent-free, atraumatic sutures. Never do again 3.0 or 4.0 in the aesthetic zone. Sorry for saying this. 6.0, 7.0. Everybody can do this. When I can do this, I'm not better than you. Everybody can do this. Train your technique, optimize your technique, and you will get success. Believe me. Because the materials, they are working. The Jason membrane, the products from Traum, the products from Geisi, all they are working. My right hand make the mistake, please. This is the problem. We have to be honest to our patients. And even important, look on this. This is one slide with, in my opinion, 98% of all information in dental implantology. The time of implantation, hard and soft tissue management, the position is very important. We learn from the prosthetic guides. Can you explain me 78%, 7-8, is the implant position and the anatomy? Not the material, not the implant, not the prosthetic, you know what I mean? I make the mistake with the wrong position. And then we talk about individual abutments for the soft and hard tissue management. Keep this in mind, yeah? Then we can talk about platform switch, microcoil implants, all these things, tube and tube connection, about bone level or something else. But this is very important. You know this. We know from a lot of guys, since over years, the ITI conference explained us, it's boring for you, but never implant an implant too close to the buccal wall. Yeah, we know this from good guys. Yeah, look on this. We don't like all our exposures of the implants. We know to insert the implant vary to the palatinal part, to the lingual part, take away every pressure, every contact to the crestal bone. Why does your implant from MIS, the V3, working so well? That's a brilliant idea. You have only 3 points, triangular. It's a crazy idea. Take away the pressure at the crestal part of the bone. Why we developed the platform switching? Do you remember? Problem of implantology is always when you insert an implant, you have the pressure and the microfracture at the crestal bone. Success in implantology is the soft tissue management, but even to avoid pressure at the crestal part, we know this. And option number one, in my opinion, is always, you see, these are new papers. I don't like to present you old things. These are new papers, old stories, yeah? Option number one, in the most cases, is immediate implantation. I always prefer to set the implant to the palatinal part. It's the oldest trick I've ever seen. Insert the implants to the palatinal part, like Randall-Sofa, like Kakashi, all the guys saying. And then fill up the defect with a bone substitute material. But the first mistake is never put a bone substitute material direct to an implant. Always a thin layer autogenous bone before, please, with a microscope or something, because in that biomaterial, on a dead implant, how should it work? How should the nutrition come there? How should it work? And keep in mind, a new paper, the old question, and I think it's very interesting. When I will be you, I will ask Mr. Smeets, why you inserted the implant directly there? Because we mostly lose the teeth by parodontitis. It's an infected alveolar. 10 years ago, at university, they told us no implantation in infected alveolar. Yeah? But now you see the new papers, it's not a risk. You can do implantology in infected alveolars, please. Yeah? This is totally new, and we see we have to do more studies about this. But the old question is, should we use antibiotics, yes or no? Once again, another study, we can be placed with periapical periodontal infections. Even when the teeth is sensitive by percussion, even when the teeth had a cyst, an abscess, they are working. 10 years ago, I would never believe this, but now we have the data. But please, I'm a big fan, use antibiotics. Use antibiotics when you have an infection there for 7 days. This is my concept. When you leave this room, you're the star, you're the master, make what you like, never change a winning system. But I like to present you my strategy. Yeah? A lecture must give you a take-home message, or even is a bad lecture. My concept is always amoxicillin for 7 days post-operatively in these infected alveolars. Yeah? Keep this in mind, please. And never forget, should we fill up the defect, yes or no? That's an old, boring story. I'm a big, big fan to fill up the defect, but not necessary less than 1.5 millimeters. That's an old story. We know it from Mombelli, Tonetti, Zucchelli, all of these guys. Homely Wong, yeah. Sorry for saying this, yeah. Please, less than 1.5 millimeters, it's not necessary. It's so old, yeah. You have a lot of good guys in Israel who did a lot of good papers for this, yeah. We know even the position of the implant. I told you, never come too close to the buccal wall. When you prepare the flap, you saw again the study from Fickel, 0.7 millimeters resorption of the bone. Now you have the position of the implant too close to the buccal wall. You get more problems. The tangent of the adjacent teeth should never touch by the implant. This is the old story, we know this. This is the reason why we are all working with guides. In Hamburg, in Germany, in the aesthetic zone, we are always working with guides. Sorry for saying this. Sure, it costs money, but we have cheap systems at the moment, 70 euros roundabout, yeah? You have only one shot. My big mentor, I learn a lot from him, he always say, Ralf, we have only one shot. The wrong position of the implant, you will lose the case, you have no chance. Yeah, we have a lot of systems on the market, you can do what you like, go out to the companies, every company had a system for guided surgery and all these things. You know this even before. I haven't to explain you this, yeah? Even the top-down planning, but sorry, I can laugh about this, yeah? This is too expensive, yeah? But I like to show you at the moment, we have the strategy, we have the chance, yeah? Soft tissue, hard tissue, with occlusion, we have now 3D, all the data matching CT, cone beam CT, with these things, but at the moment, I'm a son of a farmer, yeah? And believe me, not every of our patients are billionaires, you know. You must make the decision how expensive, and you see this. We use modern systems like Binair to work with this, to establish the workflow. This is easy implantology, in my opinion. You have the workflow on your iPad, yeah. You know what is the drilling, you know the instruments. This is easy, and this is working, yeah. It saves times, it's easy to use, yeah. Personal operation schedule for each user. This is what I like, yeah? You have your own schedule for every guy in the department and a digital protocol. This is modern implantology, in my opinion. And to avoid these buccal dehiscence defects, please, we have some small tricks and everybody can use this. And the easiest trick, you can laugh about this, I think if you have no money for a guide, use a suture. Yeah, you will never insert an implant in the wrong position. Yeah, sorry for saying this. Yeah, that's the easiest way. We know from Tano the distance tooth to an implant. When you make a mistake, hey, we haven't to talk about a peri-implantitis. We haven't to talk about bone and hard tissue management. If you make a mistake here, you will lose the case. We know this. Yeah. And I do a lot of research at the moment with infrared cameras for the position of the implant. We know the vascularization is going down, the bone is going down, we know this. This is an old, boring story, but we have a lot of problems with these data. You have only one chance. This case looks so easy, but you have only one chance. When you take all rules for the hard and soft tissue management, sorry for saying this, yeah, you have only one chance. The helicopter landing place is only one position. Yeah. Even you get problems with your soft tissue. when you're in insufficient inter-implant distance, yeah, it's not my case, but I even did these cases. I even had a lot of mistakes. Yeah, sorry for saying this. You see, this is bullshit. Yeah, you looks like Gonzo in the Sesame Street. Yeah, that's not funny. Yeah, that was the mistake of the dentist. That was my mistake. You know. Yeah, this is the wrong decision. In this case, what would be better? Only one implant, and cantilever bridge, you know what I mean? Or small diameter implants, but not this big burters, yeah? This is a mistake in the planning of your implants. Sorry for saying this. You have an insufficient soft tissue closure, but the mistake is the right hand, the dentist, yeah? Sorry for saying this. Keep in mind all the strategies. The timing of the implant is very important. Keep this in mind. All these things we have to talk about. Keep in mind the soft tissue will be the goal to success. We know this from Kirsch, from Ackermann, from all these famous guys. You know him, yeah? And always keep in mind your emergence profile. I'm a big, big fan. We are a team. The prosthodontic, the periodontal guy, and the surgeon. And we know this, yeah? The emergence profile is made by an individual basis. Support the peri-implant soft tissue. And keep in mind, we are talking about peri-implantitis in the third lecture. You will see cement-induced peri-implantitis, the reason why we use more and more screw-retained implants. You will see later the studies from Switzerland, the studies from the guys from Sweden. Keep in mind, but always talk to your patient. It will never be like before. That is a low-quality soft tissue, yeah? Functionless, avascular, structural changes. Please, it will never be like before. And then you are asking why it doesn't work. It couldn't work, yeah? Believe me, yeah? To get these results, sure, I know what you are saying. Now Mr. Smeets present his only good case. No, everybody can do these cases. Everybody can achieve these results. But in order to achieve these results, you have to keep in mind not only the surgeon, sorry for saying this, but we are a team. Once again, use the right abutments, yeah? Keep in mind you have an O-ring effect. Read the papers. Look on Gerke, look on Klenke. All these guys in Israel, yeah? You have a lot of brilliant guys there. Goldstein, Martey, all these guys. They train us a lot, they explain us a lot, yeah? And we must keep in mind here which kind, in concave and convex structure. This is what we learn now. After 70 years of implantology, we learn more and more about the individual abutment, what is important for the peri-implant soft tissue. Have you ever heard to Mr. Happe? It's a new paper, 2016, yeah? After 10 years working, now I understand how important the platform in the aesthetic zone is for your abutment. Look on this presentation in the internet, on YouTube from Mr. Happe. It's amazing. You can be the best surgeon in the world. When you make a mistake with the abutment, you will lose the case. I see your faces. I see you laughing. Yeah? Believe me. I learned this in a long, hard learn curve. Keep in mind, to go to success, I have only the 30 minutes. Yeah? A small trick for all these soft tissue management. Use the indexing. I learned it from Mr. Klenke. Please go to the prosthetic guys. Talk with your technician. In Germany, I insert no implant without talking with the technician. The technician is 50% of the success, believe me. 50% of every case is the technician. You can be the best surgeon, it doesn't work. Yeah? Keep in mind, even for the soft tissue, yeah? To get these results, we only have one chance, and we are a team for this. Yeah? The old story, it's so boring, nobody can hear it again, yeah? But when you make a mistake from the contact point of the veneers, of the bridge, of the crowns to the crestal bone, when it's less than 5 millimeters, you have a perfect papilla. 1 millimeter more, when you make the mistake, when the technician makes the mistake, you lose 44% of the soft tissue. Sorry for saying this. 1 millimeter more, 73. Sorry, the best periodontal guy in the world, Zucchelli, Suhr, all these guys, they get a big problem for the surgery of the papillas, you know this. Augmentation of the papillas, very funny. We lose a lot of cases, you know. Look on these cases, I hate these cases. Why you see the lid there, yeah? Because when you say to the lady, please laughing, you see where are the problems, yeah? I don't like these pictures. Always say to them they should laugh, yeah? Sorry? And then you see how we can solve this. With surgery, we will talk the whole weekend. But there's a small trick on the market at the moment. Have you heard about the hyaluronic acid? I use hyaluronic acid for the aesthetic things, yeah? For extraoral, for the ladies, for the guys. 18% are men at the moment, believe me. Every fifth patient is a man, yeah? But we know from a lot of guys, yeah, it's antibacteriostatic, anti-inflammatory, yeah, osteoinductive. It's amazing, yeah. Promote wound healing. Hyaluronic acid is coming more and more at the moment, yeah. Extraoral, intraoral. This is the product I use, yeah. I like to show you what I use, per your shape and per your fill. And look us in these cases, the black triangles, we don't like them. It's an easy way to do augmentation there. Nobody will believe me. I even don't believe the company, but it works, believe me. We do animal studies at the moment, we do human studies. For small augmentations, it's an easy trick to do this, yeah? This surgery, you haven't to be a dentist for this, yeah? You insert this not in the center of the papilla, not too far palatinal, yeah? Only one slide, maybe around about 0.1, not too much pressure, aspiration before, take care of the vessels, and then wait and see. It takes some days, and then the proliferation activates, and you see it's an easy technique to working. But, however, keep in mind, take care. What is the problem of this case? There was a Turkish lady, yeah, a Turkish dentist. What was the mistake? She was talking as an allergy. Sorry for this, yeah, you are not stupid, yeah, you are academic. Have you ever seen an allergy which is stopping at the rapha mediana? I never saw this. The lady hit the vessel, you know. Take care of this, yeah. You can get a thrombosis there, please. Always aspiration, like in local anesthesia, yeah. If you hit a vessel, inject the hyaluronic acid in the vessel, take care, please, yeah. No injection in the palatinal area, aspiration, no injection in infected papilla. Keep this in mind, yeah, and not too much pressure. I was looking the same like you when I saw this the first time 3 years ago. The Korean guys, the American guys do this since 10 years. It's working. We do a study at the moment, a multi-center study in the periodontal treatment. It's very good working, not only for the augmentation. In the periodontal treatment, it works at the moment. We did some study for this. You will see later, coming more and more next year. We have a multi-center study with this. Keep in mind. At the end, for my concept in the aesthetic zone, please keep in mind, soft tissue sculpturing with individual temporary restorations. In my opinion, you need this. Individual impression posts and CAD-CAM 3D milled individualized abutments based on scanned emergence profile. This is my concept. I learned from Professor Grubiano. A speaker must present you his strategy, must present his working, his details, and everything. We are not only surgery. We are not only doing the bone augmentation. We have a lot of things to talk about. I have 4 minutes left. And keep in mind, 6 weeks. Why you don't do this? Why you don't use the first 6 weeks with this individualized temporary restorations? Do you do this? I learned this only some years ago. We know at the end, the goal to success, we can talk the whole weekend, but when you make a mistake here, you will lose the case. Once again, the flap preparation, the soft tissue management is the goal to success. The right incision, the right blood supply, the right flap design. I know you're laughing, but this is, in my opinion, the important point. Look on Mario Steigmann, look on all these guys. I do a lot of hospitations. The half time of my holiday, I do hospitations. And at the end of the day, I always hear the same things. Hello? Yeah, you hear all the same things about the soft tissue. Keep this in mind. Internal mattress sutures to fix the flap in the right position, yeah, not with some steps, and then sutures 6.7.0, please. And at the end of the day, the complete flap closure over the defect. This is very important. Even by the irradiated patients, by the bisphosphonate patients, when the flap is open, when the membrane is exposed, when the bone is exposed, the bone substitute material, I never save a case when the membrane is exposed. Yeah? This is the most important point. the complete flap closure over the defect. Please, once again, look for the right flap design, look for the right flap adaptation. Can you explain me, when the flap is less than 0.8 millimeters, you will get a necrosis, you know? That's the same like in plastic surgery. When we do a microflap, we have some rules, yeah? Jesus Christ gave us some rules. Not too thin, then you get necrosis, bad nutrition, yeah? Keep this in mind. Suture technique, atraumatic, 6.0, right position of the flap, once again, please. Microsurgical techniques enhance the wound healing. It's such a boring story. You can have the best biomaterial, the best prosthodontics. Yeah? When you make mistakes in a soft tissue, I had a hard learn curve, and I learned from all these guys. Don't believe all these superstars. They have all the same tricks, believe me. But the soft tissue is the most important goal to success. Keep this in mind. Yeah? Even for the right incisions, we know from Burkhardt, we know from Esposito, yeah? Make the right incision. One of the best tricks I've ever seen. Where do you have the problems when you're harvesting a free genial graft or a connective tissue graft? You always get problems in the corner. Yeah? Why you don't crossing the incisions? I do studies at the moment with an infrared camera to analyze the vascularization. Good to see you, hello. Yeah? The problem is always the nutrition, even in these parts, like in microsurgery. Keep in mind you have a better nutrition, you see this. And this is my most lovely slide in all these presentations. Nobody in this room will save this case, yeah? Because they had the big mistake. 2 vertical releasing incisions between the canines. It's the biggest mistake in parodontology. We know this, yeah? Please, you get an avascular segment. You have no nutrition. Nobody in this room, you are brilliant. You are all good guys, but no guy will solve this problem because it is the wrong flap design. Keep this in mind. 1 minute left. Keep in mind, I learned this in a different way. In my time, for my resident time, I learned a different. Transcrestal incision should be avoided. Relief incision, trapezoid flaps should be avoided. Sorry for saying this. What did you learn? I learned it in the wrong way. Yeah? Delimited mobilization, please look on this, can also be refuted since only periostal splitting provides the required expansion. The relieving incision doesn't make the tension-free. Tension-free you will get by the perios splitting, you know, but then you get less nutrition. Once again, 90% of the nutrition from the bone is by the perios. Do you know what I mean? When you start the perios splitting, we all have to do this, sure, to get a tension-free flap, but then you have less nutrition. You must explain it to your patient. Keep in mind. You are all experts, but for the beginners, very important, yeah. Incisions should be created at least 1 tooth width away from the implant site and minimize your vertical incision. If so, do it mesially. We don't like to do it mesially. We go distal, yeah, for the aesthetic zone, yeah. But distal, they are the vessels. Ask the surgeons. Remember the anatomy. The vessels coming from distal, and you cut the vessels. And then we are talking about bad results in the aesthetic zone. It was my mistake. My right hand made the mistake. Mr. Smeets. On net the company. Okay, Dr. Neu, 30 minutes, you told me, yeah. I never stop a lecture without saying thank you. I'm a big team player, I'm Dutch, I can only standing here because I have a very good team and I learned from a lot of good guys, yeah, and I say thank you to all the guys which are helping me every day. And these are my big mentors, yeah. This is the oral maxillofacial surgeon in Aachen, where I came from in the west of Germany, and this is a prosthodontic guy which I learned a lot in implantology. Thank you very much. If there are any question, always send me an email. We are colleagues, we learn from each other. I make a lot of mistakes. It was only 30 minutes, but sorry, you could learn skiing in 10 minutes. You know what I mean? Aesthetic zone is the main topic. We can talk 3 weeks about this. Thank you very much and we enjoy.